previous book. And what chapter are we on in the new book? 39. We get to talk about the brain. All right. And most of our patients are not scarecrows, so they have one, right? Nobody like that, huh? Nobody's a Wizard of Oz fan? Okay. All right. Our concept this time, that our priority is our cognition and our mobility. Okay. The example for cognition is Alzheimer's. We're going to talk a lot about that, and our mobility is Parkinson's, which we're going to speak about quite a bit. And we want to make sure that throughout these, we keep the patient comfortable, but we also keep the family as comfortable as possible. We have to include them in our care. So Alzheimer's is, of course, an impaired cognition, and Parkinson's is the decreased mobility. And if you already have these problems and you add an infection on top of it, it's just going to get that much worse. Okay, Alzheimer's. So we have structural changes in the brain. It does go by stages. It gets worse and worse and worse. It has different kinds of symptoms. Anybody have a symptom for me of an Alzheimer's patient?
Usually, short-term memory loss.
Short-term memory loss.
I say memory too.
Memory, there you go. Okay. And then, is there any diagnostic testing for this? No, not while they're alive. You can check them in the autopsy after their death. So there's not actually a diagnostic testing. So this is pretty much determined by their physical assessment. And the priority of care, like we said, it's got to be interventions that support both the patient and the caregiver. Okay, what age does Alzheimer's typically happen? Over 65. Okay, and that's usually 1 in 10 people. It's more common in which gender? Females. Okay, and then 81% of the people that have Alzheimer's are over age 75. Okay? With the different stages, sometimes they're asymptomatic and sometimes they're symptomatic, but it'll sometimes in the beginning, you just don't know when you're going to catch it, which person you're going to get at that time. The dementia phase, of course, is the worst, but okay, if in your book, page 846, okay, and this is really good. You can see those stages in the very top left-hand corner, page 846, okay, and then the bottom that changes into cognition, where we're going to talk about attention and concentration, judgment, perception, learning and memory, communication, language, and then how fast they can process information. But you'll see this will change their personality, it'll change their behavior, and what they can handle by themselves as far as taking care of themselves. I mean, they will get to the point where they lose their bladder control. They might not be able to chew food anymore, so depending on which stage they are in. A lot of times they have major emotional and behavior changes, which will cause some problems. The other thing that's not talked about a lot until you get these patients is their change in sexuality. Okay, you might have a male masturbating. They'll go ahead and they will be obsessed with their genitals. They might make different gestures to nurses, different things like that, and people don't realize that's part of the disease process. Okay? Not always a very fun one. Our cause for Alzheimer's is unknown. They do see structural changes in the brain, but like I said, when do they find those? with the autopsy. Let's see, we talked about that. I got ahead. Okay. With this, when we're looking at their problems, and we know it's because of the neurodegeneration in the brain, we have to make sure that we keep them from accidents or injuring or wandering. And this is a huge one, potential for elder abuse by caregivers. Why would they abuse their loved one?
They're not fully there, so they could easily be confused, manipulated.
Okay, that patient can definitely do that. But on the other hand, we're talking, you are my parent with Alzheimer's, and you have woke me up 6 times in the last hour, and I'm just trying to get some sleep because I have to go to work tomorrow. What happens sometimes out of that aggravation comes this elderly abuse by the caregiver. Sometimes will just react and harm, and it's not always an intentional type of thing. But like when people become sleep deprived, like we talked about before. So that can happen, especially with the progression of the disability. They're tired. Mom, you wet the bed again. What do you mean? You just pooped. I just cleaned you up. And they're just exhausted taking care of these patients. A lot of times we have to take time and redirect these people and try to keep them from harm. When we're talking to them, it's easier to do simple questions, yes and no's, and limit their choices. Okay. We have to give professional care, the safety, that's our priority, patient safety. You'll hear that again and again. We're going to use, of course, drugs, the pharmacological intervention that we can for the patients to help with the dysfunction. A lot of times they'll find that they're not going to be able to reverse it. But like with drugs, Namenda, Aricept, those can help prevent them from getting worse as quickly. They can use an SSRI like Paxil or Zoloft for these patients. And then we have the psychotropic drugs. But with those, we have to be very careful because what happens with psychotropic drugs, anybody know? It actually is considered a chemical restraint. Okay, and if a drug is considered a chemical restraint, it stops their mobility. And our restraints, what do we have to have for restraints? We have to have an order. We have to check on the patient every 15 minutes. So it increases the risk for the patient if you're doing a psychotropic drug. So we talked about preventing injuries. So we're going to, if you think about it, we're going to keep their home the best we can, the same. We don't want to move the furniture. We want to keep their hairbrush on their dresser at that same place. We're going to keep the toothbrush the same place. We're not going to have them go for things or they can't find something. They start digging through. It'll get very confusing. But you want to keep things as normal as you possibly can. Respite Care is listed right there at the top. And caring for the caregiver because it is so exhausting for them. As far as self-management, we want to make sure we keep these patients moving as much as you can. Okay? We need to make sure we keep them moving. And keep them engaged as much as you can. Okay? The Safe Return Home program is important. Does anybody know what that would be? A Safe Return Home program. So if you know you have somebody demented, you can always let, if it's a smaller community, you can let the police know. They have identification. You can put identification on this person, just in case, because they do wander and get out. I'm going to give you an example of even last night. I had a text from my cousin. He said, I'm taking your aunt tomorrow to go get evaluated, and we've got a room for a placement for her once they do the cognitive test with her. 2 months ago, she went to go get her haircut. So she got her haircut. She arrived. Then it took her about 25 minutes as she tried to pay the bill. She couldn't find her wallet. She had her purse, but she couldn't find her wallet. And then couldn't figure out how to pay, and it was all right in front of her. And then she went to leave. Now this beautician's busy with other people. And she went to leave, and she couldn't find her vehicle. Took about 40 minutes to find her vehicle on the parking lot. This was not a big place. Yes, she had a new car within the last 3 years, but still she couldn't remember which car was hers. And then they helped her determine which car, but then she couldn't find her car keys. They called my cousin. Okay, and then, so you're accustomed to seeing mom, you go and you see them in their environment. They function much better in their environment, but when you move them to anywhere else, this is when that happens. But at first, especially if they can't find their way, they're starting to get lost. You'll notice. But it does. It happens to people on a regular basis. That you will see this in little warning signs, but you have to be astute of the tiny warning signs that are coming. Anybody in here have a family member with Alzheimer's? Okay. You're all blessed. Brenda knows. It's hard, isn't it? And it's hard to see the changes in the person. But it is, their safety is most important. All right. PD, Parkinson's disease. Who has seen somebody with Parkinson's disease? Michaela? Sarah? Okay, Bailey? Good deal. What do you notice about them? Before we get started. Tremors? One hand or two hand? Two, so that tells us what stage. Okay. Anything else about them besides tremors?
Eyes twitching.
Eyes twitching. Okay.
Head twitching.
Head twitching. Everything pretty much gets going. All right. And so this is a progressive neurodegenerative disorder. Okay. It's very debilitating. It gets rid of their mobility quick, fast, and in a hurry. Like the ladies talked about, you'll see tremors, the muscle rigidity, so everything gets very stiff. Okay, they have a hard time with mobility for certain. I mean, especially when you go to stand these patients up. You're in the hospital, yeah, no, they got Parkinson's, but if you haven't dealt with them, it may take 2 minutes to get them up out of the chair because they're not able to move those muscles. Everything is very rigid. To get a pill down in, sometimes even the swallowing and the action, you may be in there for their medication pass. You think, okay, I got 2 more rooms. I've got to get all this medicine passed. It may take you 15 minutes in there just to get their pills down. Okay? And you have to be very careful with that. What's bradykinesia mean? Slow movement. Brady, slow. What's akinesia? No movement. Good job. Okay, what are our risk factors? We talked about the risk factors, over 65, female. For Alzheimer's. What about Parkinson's? Male. Yep. They have an increased risk over 40 years. Now, I find this interesting. Exposure to pesticides, herbicides, industrial chemicals, and metals. I wonder why it's more prevalent in males, huh? If you think about, here's your farmers, here's your iron workers, industrial workers. Okay. The progression here, stage 1, mild to stage 5, is on page 854. Box 39.1. So like they said both hands. So both hands would be a mild stage 2, the mild stage. One limb, unilateral, is initial stage. Okay? So you might want to be familiar with that. And also at the top there, table 39.3, has Huntington's disease. Huntington disease is hereditary instead, and that's an uncontrolled jerking, rapid movements from your limbs and your trunk and your facial muscles. So everything, your facial muscles, your trunk, and all your limbs. And that one is usually young and middle age, and it's misdiagnosed as Parkinson's. But it really is Huntington disease, which instead is hereditary. All right, interprofessional collaborative care. You're going to hear a lot about collaborative care as a nurse because you're going to have all these other helpers at the hospital. Who's going to be on your collaboration care team at the hospital that you're working with? Social worker, case management, PTOT, physicians, telemetry techs, your clinical partners, everybody. Okay, so together, everybody's noticing, and you may notice different things on them. Like we talked about the rigidity, their facial expressions. What happens to their facial expression? Very flat, very flat. Kind of like a mask, like they're almost like they're wearing a mask. Bowel and bladder changes, and that emotional change. Sometimes they can get very angry. I mean, how would you feel if you've been able to do stuff all your life and all of a sudden you can't move? You can't do anything. A lot of times they get very angry. There are not any specific diagnostic tests for this either. The way it works is the dopamine is lost to the brain, and so the Parkinson's interferes with their movement because they don't have that. It decreases the sympathetic nerve influence on the heart, the cardiac blood vessels, and also for the body, orthostatic hypotension, drooling, and nocturia. I recently went and saw a precious lady to me. I didn't even know where she was, and it ended up her husband showed up at this church where I was playing the piano that morning. I hadn't seen him in 10 years, and I looked over as I was going in. I said, "Leon?" And he looked at me. I said, "How's Alice?" And so he's elderly too, and so he starts telling me. He didn't even realize who I was, okay? But that's all right. So I found out where Alice was, my good friend. And I got to go to this nursing home to see her. And it was actually not a nursing home, it was an assisted living type of place. And I got to her, and her face, hopefully I'm not in trouble for this. And I was like, and the whole time, she had talked to me, but she was drooling, just constant. The drool, she couldn't help it. She would try to keep wiping. But she had, when I had lost track of her for 10 years, they had moved different places I had moved. She could no longer move. She had stayed in her chair for the last 3 years. She had not been able to go to bed. Broke my heart. But I mean, I knew immediately with all that drooling what was happening. But I can tell you, cognitively, she was there. So we FaceTimed my son. This was his babysitter from 6 weeks on, okay? So Miss Alice to him is very important. And of course, he has a son, and so he wanted her to see him. So I FaceTimed, and she was like, "Okay, Stuart," she talked to him about discipline, that you never put the baby to bed if they're misbehaving. You put them on a chair in the corner. She gave specific instructions. Of course, she was a babysitter. And she said, "Now do you have him in church? Are you in church, and are you going to church?" So she made sure to get important life things in. It was cognitive. She had not lost. But all that physical ability was gone. So hopefully I will get to see her this next weekend, because I'll go back and give her some care, just like she cared for my children. So yes, but you can think of Miss Alice just sitting there drooling and in a chair for 3 years. Oh, killed me. See how he's got this pan face? Kind of looks like nobody's home, but like I said, their minds can be there. They just can no longer move. They might not be able to talk as easily with their speech. Very sad. Also, sometimes it's called the freezing disease because they go to move. And it's almost like, everything, they stop and they freeze. I already mentioned that in the late stages, trouble chewing, swallowing. They become very depressed, irritable, insecure, and anxious. Okay, this talks about the decreased mobility, just from the tremors, and postural instability. So you may get them up from the chair, but they're like this. And they are not steady for anything. What do you always have to have on when you get a patient up out of bed? Who's that for? Is that for the patient or for you? Both. There you go. You definitely have to have that. And here talks about the self-esteem, because they're no longer able to take care of themselves. And tremors. Okay. Things we can do for these people is we can go ahead and we can promote mobility, keep them exercising as much as possible. Physical therapy helps with that. We can also do some drug therapy. Any idea what some of the meds are that you might hear of for Parkinson's disease? Could be. Okay, Cinnamon you might hear. You might hear Compton. And then the other thing is the different drugs they're on. They may take a vacation or a holiday from the drugs. They may totally stop and take them off the drugs for about 10 days. And they do this to see, was a drug actually helping? Do we need to start something different? Do we need to increase a dose? What type of thing do we need to do with this patient? Because there will be a buildup of the drugs in their system. It talks about, so after drug therapy, the stereotactic pelidotomy. So this is a surgery. Okay? That's not very common. And then the deep brain stimulation. I've not ever seen those. Of course, depending on where your nursing path lies. But the deep brain stimulation, that's kind of like the pacemaker for the heart, only it goes to the brain. They're trying to stimulate that. All right, the other thing that you can do that's not listed on here is some of it, they've done some fetal tissue transplant. And of course, what that does is give us some political and ethical issues, big time. We want to help promote their self-esteem, and then we do our best to keep them at home if it's okay, or prepare them at home, prepare the family for what's going to happen. You have to teach them things that be prepared for. Get rid of those throw rugs. Make sure the meals are simple. Make sure their food's cut up well. Small things like that, but they all make a big difference. And make sure they know their resources. Questions on Parkinson's? Okay. All right. Migraine headaches. Who's had those? It is not fun. Michaela, anybody else? All right, Caitlin, yeah. They are not fun at all. All right. Recurrent episodic attacks of head pain. It's usually throbbing, and it's usually one-sided, unilateral. They can last anywhere from 4 hours to 72. Can you imagine having that headache for 3 days that you can't get rid of and it's hard to function? Okay, because those neurons get so hyperexcited. This can be from vascular problems, so we've got too much blood flow. It can be from genetic, and it can be hormonal, and there also could be environmental factors. So who do we think typically has more migraine headaches? Females do, especially that hormone. Hormone component. It can be accompanied with the symptoms of nausea, sensitivity to light, or sound, or head movement. You just want to hold and you don't even want to go anywhere. Light sensitivity is big. And there's some triggers, examples of caffeine, red wine, MSG. Could be beer. And any kind of tyramine. Does anybody know what has tyramines in it?
Old age cheese.
Cheese, old age cheese, like a processed sausage or lunch meat. And there's our red wine is on that list too. Any kind of processed food. Let me tell you, to go off one of those diets for tyramine is horrible. You can't have any mustard. You can't have any mayonnaise. You can't have cheese on anything. It's like, for a while then you go, what can you eat? But sometimes it works for people and they find out if that's what their trigger is or if it's not. But you would have to go on that for 90 days, which is a really long time, I promise. And it didn't make a difference. I still had the headaches. It was not fun at all. Okay, priority care is what? Pain management. And what is our best way to manage their pain? The main thing is you have to remember to start it early. If you can catch that headache right when it first begins, you're much better off. Because they can usually, if they can go to darkness, if they can lay down, limit the movement, and get rid of the stimulus, is the biggest help. And sometimes helping with the medication. Okay? And let's see, I got it on here somewhere. Thought I did. Okay, let's talk about the drugs, the typical over-the-counter drugs that you would use. What would you use for a regular headache? Tylenol,
Ibuprofen.
ibuprofen,
Aleve.
naproxen, and caffeine. What good is caffeine going to do? How does that act on the body? It's going to narrow the arteries. Okay, so we don't have as much stimulus. Okay? One of the things I was doing is I was taking Excedrin. I like Excedrin. It works for me, typically. But anything over 3 times a week, I got in trouble for. I had no idea I couldn't take more than 3 doses of Excedrin a week. What that does is it can cause rebound headaches. So you'll hear of the rebound headaches too. Not very fun. Because then the body's getting so accustomed to it and used to it. Anything else on migraines? Just remember they can be quite debilitating. And until you can get them under control, people may lose too much work, not be able to do and function the way they need to. Or to take care of their family or kids. And if somebody has a migraine that's feeling that bad and those kids keep bothering them, so there's a lot of things you have to work on with families and the environment.
Can you have a question?
Sure.
Are you pretty familiar with migraine meds? Prescription ones?
I've had to use some, yes.
There is a drug that they'll give you if you have a migraine, and it breaks the cycle.
Mm-hmm.
And young females have a reaction to it.
And they have a reaction to
A
it?
reaction, like an anxiety reaction to it.
Anybody want to Google that for us?
I tried Googling it.
Try Googling it and couldn't come up with it? Do you
Yeah,
know what-
I can't, because I had a reaction to it, and I'm allergic to it, but I, for the life of me, cannot remember the med.
Imitrex, Triptan, Topamax, Verapamil. What is Verapamil? Have you guys had that one yet? Calcium channel blocker. Propranolol. Which one did she say?
Oh, no, it's not Compazine. Never mind, no.
Okay.
Yeah.
You can use the Compazine because you're going to be nauseous, but it's not actually going to treat the migraine. Okay? All these are drugs: Imitrex, Triptan, Topamax, Verapamil, and that one's a calcium channel blocker. What is propranolol? What kind of drug is that? Beta blocker. Okay, so what are those going to do? Decrease our heart rate. Okay. All right. How many migraines do you have to have in a month to be considered chronic migraines? Over 15 in a month. Yep. Not very fun. Okay. All right, we ready for seizures? Does anybody need to stand up? Move around? Anybody getting too sleepy? Yes, Brenda?
Question regarding the 15 a month, does that mean, like, does one headache that lasts for days count as one? Or is that like...
I think that's a great question. I got this from the book. I don't think it tells us that. Some patients experience chronic migraine, which is defined as having 15 or more migraine headaches in a month. It does. That's all it says. That's a great question. I don't know how I would interpret that any different. What do you think, Darla?
Do that one more time.
Okay. She asked if 15 headaches, is that what if one that lasts the 72 hours? And there's no way you could, get 15 in if they were all that long. But according to our text, some patients experience chronic migraine, which is defined as having 15 or more migraine headaches in a month.
I need to check with Jen and come back to you.
My thought is, this just comes from what I had with my neurologist. I don't have an exact answer for this, but it would be 15 days that you are suffering.
Oh, okay.
But we can check with Jen
Okay.
to see if there's something different, because that's what...
That makes sense. I mean, I feel like maybe they're just trying to, like, if it's half of the month that you're in pain, like, I feel like in the end, it doesn't matter how many days, it's just 15, just to put a number on it, maybe.
Yeah, because you say, I remember him asking me, how many days are you,
Yeah.
and then with the medication changes, how are they now? That kind of thing. All right. Seizures. Seizures versus epilepsy. Okay, so we have generalized seizures, partial seizures, and unclassified seizures. These break down, and there's a great breakdown on page 863 in your book. Okay, generalized seizures are for both cerebral hemispheres. And the physician's going to ask you, was it clonic or tonic motion? So clonic motion is the rhythmic jerking or biting. The tonic motion is very abrupt and it increases the muscle tone, but decreases the level of consciousness. That is usually, the tonic-clonic seizures are usually 2 to 5 minutes. Okay. There's a myoclonic, which is still a general seizure, and that's a brief jerking or stiffness, which just lasts a few seconds. There's an atonic generalized seizure where there's just a loss of muscle tone, and it's followed by that postictal after seizure confusion. And the physicians will ask you, well, how long did that postictal phase last? That'll be a question they ask you. They want to know because, especially neurologists, they are putting it together. Now, for the partial seizures, there is a focal or a local seizure, which just involves one side of the brain, one hemisphere. There's a complex partial, which is a blackout of 1 to 3 minutes, and amnesia follows. There's a simple or a conscious seizure, and that one has an aura before it, and it's just unilateral, one-sided movement. They may have an increased heart rate, weird sensations, skin flushes, epigastric discomfort. And then the unclassified seizure, we have no idea why that one even happens. It's idiopathic. So, the thing I really want you to remember about all these different kinds is the fact you have to pay attention to the timing, what you see in the patient, because these are the things the physician's going to ask you, and you'll need to know what you're documenting. You won't have to label it specifically, but you'll need to pay attention with your assessment to that patient. Because remember, you are the eyes, ears, you're all the senses for this physician. You have to be able to give him an exact picture of what happened. Okay? Epilepsy. Epilepsy is a chronic condition where there are repeated and unprovoked, there wasn't something that we know started the seizure. Okay? The seizure risks. They may result from metabolic disorders, acute alcohol withdrawals. Anybody seen a patient like that? With this, they're no longer getting their alcohol and they have seizures. Family gets upset. They call EMS. They're having seizures. Bring him to the hospital. I don't know. He's having seizures. Does he drink? Well, yeah, every day. He ran out. That is why. Many, many times. Electrolyte disturbances, heart disease, high fever, stroke, and substance abuse. There's a secondary wave for seizures, and that is also from a brain lesion, a tumor, or trauma. All right. Interprofessional collaborative care, seizure precautions. So that's everybody. This is somebody we left out on the picture before, RT, respiratory therapy. They are really some of the true heroes with COVID. I cannot tell you enough how we cannot survive without RT. So respiratory therapy also helps us with, we've got to be ready. If a patient is on seizure precautions, this is what you need to be ready in the room. You need to make sure you have access to oxygen, suction equipment, so that suction regulator on the wall, and the tubing, and the little yanker. Do you know what I'm talking about, that equipment? Okay. We have to make sure we have things to keep their airway open. Okay. IV access, which is very important, so we can push drugs if we need to stop the seizure. Side rails up and padded. Now, in the book, it does tell us that the padding is not necessarily always the right thing. They don't usually harm themselves as badly. It kind of depends on how the seizure activity. But because they're saying if they're more cognizant and awake all the time, that's an embarrassing thing to have the padded side rails. So you have to choose, is it more their safety depending on the patient, or is it more for their mental status? Okay? Okay. The seizure management depends on the type of seizure. So, of course, we're going to observe, document, keep our safety in place. If they're having a seizure, if we can get them on a sideline position, and we don't ever put restraints, and we don't ever force anything into the patient's mouth. You might have heard that as an old treatment people would try to do, because they're going to swallow their tongue, That cannot happen. We get them to the side and will not block their airway. Okay? We have to make sure for these patients that we maintain their drug therapy. It's very important that you teach them, you're on this medication, you have to take your seizure medication. They cannot miss doses of that. It's the one that, you need to remember to take this, so take your cell phone and set the alarm on it. So every day you know to take this at this time. All right. How do we check their blood levels of things? With regular lab work, they have to make sure they keep their appointments. And the other part is, so children may have seizures, right? But as they grow up, they've been on this medication, and they can build up a sensitivity with age. So a lot of times people will be admitted because they had seizures because they haven't had any for 8 or 10 years. But now the sensitivity is not the same for them. So they need to change out their meds. Acute seizure management. Depends on the type of seizure. We talked about there's several different kinds, right? Complete, partial. Medication for tonic clonic seizure activity may include Ativan is our friend, and so is Valium. You will have those the most, Diastat, and you can do IV Dilantin or Cervix. Okay, what happens if they've got a seizure? They're going to look, what are they going to look like? Has anybody here seen a seizure? Okay, all right. What do they look like?
She laid down, there was her whole body was twitching.
Purple, the whole body was shaking. They laid down. Okay. Did they lay down on their own will? No, just boom, they were out. Who? Okay, Sarah?
Yeah, convulsing, head was just angry.
So what'd you guys do for them?
I called her rapid.
Called a rapid response. You must have been in a hospital. Very good. Exactly.
I just held her head until it stopped.
Held her head till it stopped. Did you know that she had a history of seizures?
Yeah.
Okay, so you were kind of aware and knew that was going to happen. I was in a restaurant once. The gal I went on vacation with, my daughter was with me. I think we were at what is it, the Rainforest Cafe down in Orlando, I think we were. And just enjoying our time, having a meal, talking, laughing, and phew. And this was a nurse I was with. Bam, seizure. Hit the floor. And whoa. And Sarah, of course, was 7 or 8. She was scared to death. So, made sure her airway, made sure she was okay. But before I could do anything, they, called the ambulance. We think it was even heat related because we had been out in the sun all day. But she had had no history of seizures. As far as I know, she's not had one since. So you never ever know how it's going to turn out. But this is the most important thing you need to remember. They can, status epilepticus, very, very serious. Prolonged seizures that last more than 5 minutes or repeated seizures over a course of 30 minutes is a medical emergency. If seizures go on for over 10 minutes, they can cause death. Okay? So you've got to act fast. What drugs did I just tell you that you would probably use quickly? Ativan? Valium? Dilantin. Those will be used in the ER quick, fast, and in a hurry. Number 1, we've got to establish an airway because they become very hypoxic. ABGs, so we can determine if their lactic acid is up. Metabolic acidosis will cause the lactic acid. IV push, lorazepam, diazepam. We can even use rectal diazepam in a loading dose of IV. They also become hypotensive, hypoglycemic, and they can have cardiac dysarrhythmias, cause renal failure, and electrolyte imbalances. This patient crashes quick, fast, in a hurry. You want to hear those again one more time? Hypoxia, hypotension, hypoglycemia, cardiac dysrhythmias, lactic acidosis, renal failure, and electrolyte imbalances. Okay, talked about this, touched on it a little bit before, the drug therapy. We have to make sure that we have the most current blood level of medication if appropriate. Be aware of any drug-to-drug interactions or drug-to-food interactions. Maintain the therapeutic blood levels for maximal effectiveness. Do not administer warfarin with pelidotomy. What's warfarin? So no Coumadin with Dilantin. Okay, document and report side and adverse effects. surgical management, they can put a vagal nerve stimulator. Okay, once they put that in, if they put the stimulator in, the patient carries a magnet with them. And if they feel an aura coming on that they're going to get seizure, then they go ahead and cover with the magnet. Not very often do you see an anterior temporal lobe resection. And I've not ever seen the partial corpus callosotomy. Okay, so you won't see that very often.
So the vagal nerve stimulation,
Uh-huh.
that's the one where like you're sitting onto it and you strain and like to pass out right then.
Mm-hmm. Like if a patient's going to the bathroom?
Yes.
Mm-hmm.
Why would you want to stimulate that? Would that cause?
Okay, well, your vagus nerve.
No.
Okay, what's it going to do? It's going to slow down the heart rate. So with a seizure, we've got all this activity on. And if you get the heart rate down, it's going to get your sympathetic nervous system to calm it down. Then you might be able to stop it. Did that help? Okay. God bless you, yes. Care coordination and transition management. Here we go again. Social services, resources to assist with medication costs. A lot of these people have trouble working, right? Are they able to drive? They're not able to get a driver's license. Okay. We have to make sure that, can they drive heavy equipment? Do you want them to be a truck driver? You think of all the jobs and the risk for that. So it's very important. They do need employment. They also need to feel needed. Everybody needs to feel needed and wanted. So they're going to need that with the socialization too. So you may need some vocational rehab so that we can help and subsidize so those people truly can become disabled. All right. Let's try to get through meningitis. All right, 2 kinds of meningitis. What is meningitis? Inflammation of the meninges. All right. Meninges of the brain and of the spinal cord. Where can, viral meningitis could be from other areas of viral infection. So it could be herpes, simplex or complex, chickenpox, shingles, HIV. Those are all viral infections that could end up there. Bacterial meningitis is extremely contagious. You can, what other areas like we just talked about for viral could, you get like otitis media. So you think, does everybody know what otitis media is? Have you had that yet? If you've had children or you've had chronic ear infections, otitis media. Ear infections, chronic sinus infections, tooth abscesses, and even tongue piercings. Woohoo! You can get meningitis if you got an infection. Anything up here, it's very quick to get that infection to spread. All right, but what's the one you hear about the most? You guys are college age. The meningococcal, the medical emergency with the increased death rate in 24 hours. You guys all had to get what kind of shot before you came to school? What's that? The vaccine?
Oh,
Yes. Because if you're in like a group in the military, they have to have them. If you're in a group of a dormitory, you have to have this before you can go to college. All right. Okay, what kind of symptoms do they have? You're going to notice a fever. They will have a headache, photophobia. They don't want to look at light again. You'll look for indications of increased intracranial pressure. What's the nuchal rigidity? Anybody know what that is? That neck is very stiff. They don't turn and look at you, They turn their whole body, right? So if I'm gonna look at Rob over here, I can't just do this. I have to, because I can't move my neck to look at you. Nuchal rigidity. Uh-oh, hot flash?
Yeah, maybe.
Get that mask down, yeah. All right, positive Clonics. That's if you have the patient down, if they can't extend their knee, and if they try, gives them a lot of pain. And there's 3 different parts to the Brzezinski signs. One is getting a reflex from the cheek. One is you can tell even just taking their blood pressure, because the pressure on the forearm, okay? And the other one I've not seen done, but the pubic symphysis, so they would be pressing on the pubic bone, and then the legs would come inward. All right, let's see. Decreased mental status, neurological deficits, nausea and vomiting. Okay, what are we going to do to find out if they have meningitis? We talked about what kind of tests do we have, or what kind of intervention? Spinal tap, yep. For the cerebral fluid analysis. And so they're going to check it. What kind of things are they checking it for? Bacterial infections, the cell count, white cell count, differential count, and looking for protein as well. They can tell by a CT scan, blood cultures, the counter-immuno electrophoresis. They're looking for the chain reaction. We're checking the CBC and x-rays to see if there's any other kind of infection that could have led to this. We use broad-spectrum antibiotics, okay, anticonvulsants, steroids, sometimes they do, sometimes they don't. And so you were working, patient, you were working in the ER, okay, or you're doing your clinical in the ER. Patient came in, okay, they didn't know the exact diagnosis when the EMS brought them in. They knew they had a fever, and it's in the middle of COVID. This person's got a fever, they got a headache. What kind of symptoms are those, right? And they end up having meningitis. Okay? So, if you were in that room or taking care of that patient, you have now become exposed. So, what do you get the benefit of doing? Yep, prophylactic treatment of anybody that was in close contact. So, depending on the results for the patient, you might not find out till 24 hours later after your shift, because they finally find out that the patient was positive. You went home at 7 a.m. They didn't know that till 2 in the afternoon, that type of thing. So the employee health nurse knew by 4, since they found out at 2. And then she's got to go back and retrace who was all in that room. Was there a radiology tech? Was there somebody from lab? The physician? Oh, we've got clinical partner. So everybody involved will have to be talked to and treated. And it's been an hour. It's been an hour. I'm going to stop here, and they get a 10-minute break.